Yeah, thanks everybody. My name's Sue Kilroy. I'm the director of the Nursing Sim Lab at Temple University within the College of Public Health. And I'm here today with my friends and colleagues to present our program called the Patient Voices Program. And so I'm here with Blaze Brown, Beth Marks, and Bridget Brown. And this project originated at the Schwartz Simulation Lab at UIC College of Nursing. So it really is a beautiful place. So if you ever have a chance, I would definitely recommend to take a tour. Okay. So I thought today we would talk about I'm going to talk about the background and development of the program. Then I'm going to turn it over to Blaze, who's going to talk about the research, the implementation, and the results of the program. And last but not least, we're going to turn it over to Bridget, who's going to talk about her experience as an SP or a simulated patient. So starting with the background, just so you know, UIC has approximately 34,000 students. It has 7 health science colleges. IPE is an essential or an accreditation requirement for multiple colleges. UIC also has a very robust IPE steering committee, and their mission is to create transformational change in health professions education and healthcare service delivery by delivering evidence-based learning experiences that build collaborative competence. So right now they have a great foundations course that's been running for years. It serves over 1,300 students from 13 different professions. And what that course does, it evaluates their attitudes and perceptions towards collaborative practice. And so our team was thinking about the next level, like looking at behaviors. So that's where the simulation lab came up. And so to develop a second level IPE course. And our goal is to measure and evaluate interprofessional behaviors and perceptions, even if they're self-reported. And so this program builds off the foundations course. And like I said, it started in the Schwartz lab, and the team used best practices through SSH, which is the Society for Simulation in Healthcare, and NAXL and ASPE when we were developing the program. So just to give you, this is a broad overview to give you a timeline. So in the fall of 2020, through the IPE steering committee, I met Blaze, and working with him, he always wanted to develop a program where students can learn with and from individuals with disabilities. And I always talked about developing an interprofessional sim. So he called me one day and he's like, Sue, can I come tour your lab? I'm like, sure. And then he came up with the good idea of let's just combine our 2 projects. So that's basically where it started. In the spring and the summer of 2021, through Valerie Gruss and Blaze, we met with the disability department, and that's where Beth Marks came on board. And we also were able to meet community collaborators, which were also very important to the program. In the fall 2021, 2022 winter, we applied for funding and IRB approval. We got funding through the IPE steering committee at UIC and also funding through 2 faculty catalyst awards. In the spring and the summer of 2022, we recruited and trained our facilitators and SPs. All our SPs were interviewed over Zoom, and then they were brought onto the project. And then in the fall of 2022 is where we implemented the first program, and it ran over 9 weeks and included nurse practitioner, dentists, and pharmacy students. So that gives you like an overall picture. I'm just going to drill down a little bit now. So one of the things we did was start with the why this was so important. And if you look in the literature, a survey of United States ADA physicians practicing in the outpatient setting reported the following: 71% lack knowledge as to who determines the needed accommodation. 68% felt at risk for ADA lawsuits. 36% had little or no knowledge about legal responsibilities, and 21% did not know who pays for care. And then also we thought it was really important that including people with disabilities as SPs can prepare a new generation of clinical professionals to offer the highest level of care, have an outward purpose that includes caring for marginalized patient populations. And another thing we talked a lot about in the development was simulated patients with disabilities, because it highlights the need for patient-provider concordance in healthcare delivery to improve outcomes. It improves quality healthcare inclusive of disability and cultural competency. It also can redesign environments and structures beyond individual healthcare practices to support diversity, equity, inclusion, and accessibility of all patients. And last but certainly not least, it was identified as a gap in our healthcare profession curriculum. We realized across multiple professions, students didn't have the opportunity to work with or learn from individuals with disabilities. So that was another important part. So now I'm going to kind of move into the logistics and talk about the faculty and sim staff, the simulated patients, and the students per logistics. And I just, for anybody who's thinking about implementing this, I always remember this quote from Martin Luther King is, always take the first step in faith. You don't have to see the whole staircase, just take the first step, because there were a lot of meetings where we were like, where's the funding coming from? Or where are we going to find these actors? Or a lot of unknown questions, but we just kept meeting and things kind of fell in place. So the logistics for this faculty and sim team, we trained simulated patients to 2 oral health medication-centric cases. We recruited and scheduled students from our DMP, pharmacy, and dentistry programs. We scheduled students and simulated patients over a 9-week period. Facilitators completed IDD and debriefing training before they signed up to be facilitators. And then we implemented simulations both in person and for telehealth. So here is our wonderful interprofessional team. I wish I had time to talk about each and every person, but just so you know, there's faculty from dentistry, from pharmacy, from nursing, faculty from our disabilities office, our SIM team and our SP educators up there, and then 2 community members who we hired as healthcare coaches, which I will talk about a little later. But the program would have never run without all these wonderful people, because it was a lot of moving pieces. The other thing that faculty did before, we developed 2 simulation cases, and they're medication-centric oral health cases. And so case 1 presented a 21-year-old patient with a disability who came to the primary care clinic complaining of prolonged episodes of pain to the face and jaw. The diagnosis included trigeminal neuralgia, depression, and GERD. In case 2 was a 20-year-old patient who had access to care and financial challenges with a complicated home life, also had poor follow-up to medical care. They presented to the clinic with bleeding gums, and the diagnosis include gingivitis, hyperplasia, and generalized seizure disorder. So each actors were put into 1 or 2 groups and learned only 1 case so they could really hone their skills. So moving to our simulated patients, here's some of our wonderful actors that took part in the program. So thinking about their logistics, first we developed collaborations with UIC Theater Department and UIC Office of Disabilities. We recruited the SPs from both groups. We trained SPs through in-person workshops and Zoom meetings. We had one-on-one training with our SP trainer, scheduled SPs over a 9-week period, and then we would meet with the SPs for constructive feedback and finally submit invoices and payments. So there's some of our SPs who are also still in the program this year. They're still working in the project this year too. And I know I talked a little bit about the workshop. The initial summer, we had 3 in-person, we had both in-person and telehealth workshops. And I'm not going to read this whole table, it's a lot of information, but I'll just give you a couple examples. So like one workshop objective was to promote team building. And we did this through an activity called theater games. And the rationale is playing games enables the participants to experiment and discover in a relaxed, enjoyable atmosphere without pressure. Another one is objective was to demonstrate realistic pain depiction. The activity was technique exercise, and the rationale was to help with realistic pain depiction while protecting the SP from any personal trigger. Another example was demonstrate realism. That was done through one-on-one rehearsals, and that enables the trainer to know correction and adjust patient depiction. And I just want to say before I leave the screen, we had a wonderful SP educator, Chris Karsmar, who did a really great job of getting the actors where they needed to be. He was also really great about reaching out to faculty after the simulation day and saying things like, how did your day go? And if we gave any constructive feedback, he would reach out to the actors and coach them to where they needed to be. So he was a really important part of this project. And then thinking about the logistics for the students, what the students did was they completed the IPEC Set 27. They completed IDD curriculum and online modules. Then they attended the simulations and debriefings. And then after that, they completed a post IPEC Set 27. And you can see in the little red square, the first year we used intellectability curriculum in ID healthcare. And you can see there were 6 modules, everything from IDD basics all the way down to bringing it all together, and case studies in IDD healthcare. So the other thing I want to say about the students, the nurse practitioner students got credit for this day. They got project hours, up to 10 project hours. The dentistry and pharmacy students substituted a clinical day to come to this project. So thinking about implementation, it was implemented over a 9-week period. We ran 108 simulations. That includes, we had a telehealth branch and an in-person simulation branch. 68 students completed the program. We utilized interprofessional teams that was 7 facilitators, 2 health care coaches, and 15 simulated patients. And I just wanted to talk a little bit about the healthcare coaches. They were members from the community. One was a social worker and one was a theater advocate. And the reason we brought them on, you can see in the picture there, one of our health coaches is there with Bridget. Because thinking about the SPs, both groups, the theater students and the individuals with disabilities, are considered vulnerable population. So we wanted to make sure if there was ever a scenario where they didn't feel comfortable coming to me, the actors, and asking something or saying something, or to Blaze or to anybody who was running the program, they had an advocate, especially for them. So that was their one role. And then their other role was they learned all the cases. So if an actor came to us and said, you know, I really want support during my simulation case, we could embed the healthcare coach in the case, and a lot of times they played the cousin of the patient, you know, coming to the appointment with them, or the person that worked at the SCILA or the group home. So they were a wonderful asset to this project too, and they really supported the actors throughout the project. So now I will turn it over to Blaze and let him take it away.
Let me unmute myself. Thank you, Sue. Before I start going through this, just a comment I'd like to make. You know, when I was thinking about doing this project, and it's far outside any of my responsibilities that I have at the College of Dentistry here at UIC, this really became, I've been here 19 years, and probably the most significant thing I think I've ever done. You know, so I'm really excited that it's continuing. And Sue actually made this a lot easier than it really was for me. So. Anyway, so we did have an IRB. It was a research project, and we wanted to, in the purpose, to really look at the influence of primary care simulation experiences with simulated patients who were portraying patients in underserved or vulnerable communities, and then look at the healthcare professionals, students' self-efficacy for collaborative practice behaviors. And we did this, as Sue already said, with dental students, pharmacy students, and nurse practitioners. And we also explored their perceptions and even their feelings about caring for individuals from underserved communities. Our design for the study was a mixed method design, typical with many IPE studies. We use the IPEC Set 27, which is a validated instrument. And then we recorded our debriefing sessions and went through each of those recordings to extract data. Next slide, please. So this was about interprofessional education, and you know, the idea of here at the university, we, as Sue mentioned, we all have these as accreditation requirements, but they're also an exciting part of where healthcare is going. and we're really hoping that we're going to change our healthcare system by doing this at the educational level. So the idea of interprofessional collaboration is creating teams and not just improving health outcomes, but really addressing everything on the quintuple aim. Next slide, please. So with interprofessional collaboration, the idea is we're going to yield better health services, better outcomes for populations. We're also going to be able to address the needs of populations that oftentimes have not had their healthcare needs met. And collaboration occurs when students learn about each other and they have respect for one another. And each other's professions, and they're willing to do this in a cooperative atmosphere. And doing this requires purpose. You really have to do things on purpose. It doesn't happen just by putting people together. And so our design here, which was simulation, followed other types of designs that have been done didactically and also in clinical care education. Next slide, please. Our theoretical frameworks were working with IPEC competencies. We measured all 4 domains of the IPEC competencies. Those would be the 2016 IPEC competencies. And that was using the IPEC set survey. And then we also used PEARLS. PEARLS was something new for me. And there are 5 different phases in PEARLS, and I'll tell you what that is in a minute. But an emphasis was placed on one part of the PEARLS, which is the analysis. And this is where students discuss their collaborative practice behaviors, what had happened in the simulation, how they felt about it. There's a couple of slides I have that I'll address that information. Next slide, please. So these were the sim case learning objectives, and they were framed around the IPEC competencies. The focus of our study was really on teamwork and team-based practices, communication practices, and roles and responsibility for collaborative practices. And that would be the IPEC competencies that are listed under those domains. We also addressed community and population health. And although we didn't have specific competencies from the ethics and values domain, as I like to say, in each of these other domains, teams and teamwork, communication, et cetera, that ethics and values was somehow imbued in that and came out in our debriefing and analysis. Next slide, please. So here's a shot of the simulation lab. Bridget and I are actually sitting in the sim lab right now over at nursing. I escaped from the dental school. And our purpose was to prepare collaborative ready healthcare professionals to care for individuals with disabilities or those from marginalized communities. The design links, as I already said, the IPEC competencies with the collaborative simulation and debriefing using PEARLS, and our medication-centric cases focused on caring for patients with medical, oral health, and significant access to care needs. Next slide, please. One reason to think about including individuals with disabilities as standardized patients really goes back to the fact that these individuals and as a population face a great disparity in healthcare access and in healthcare quality in our nation and actually in most of the world. Many people with disabilities or developmental disabilities live in poverty. They have high unemployment, and all of that. These are social determinants, and just those facts are reflected in their lack of access to healthcare. But there's many other factors, disadvantages, and other determinants. There's great inconsistency in the education of clinicians about care. As we know from the literature, that there's actually bias and reluctance to care for individuals with disabilities. And perhaps the biggest area or the most significant disparity when it comes to access and actual care is with oral health. with patients who have disabilities. So the idea was really to create the simulation with standardized patient actors who had disabilities or were from marginalized communities as a way of getting our students to just have another experience interacting, talking, learning about communication, learning about themselves, seeing how a team can interact with patients who typically they might not have a lot of interaction with in their educational programs here at UIC. Next slide, please. So this is the Pearls, the debriefing tool that we used following the actual simulation itself. Pearl stands for Promoting Excellence and Reflective Learning in Simulation. And I'll have to say I really like the Pearls model, since I did say it was new for me. You go through Pearls and you set the scene, you check for the reactions and sometimes the emotional reactions of the participants. There's the description, which oftentimes is the diagnosis, or you ask the students to review the entire case. An analysis is done. Then there's application and summary. You try to link this with the IPEC competencies while you're doing it, and in the end, focusing in the debriefing process with using specific questions and in some ways kind of ad-libbing as a facilitator and trying to see where students were going in terms of their thoughts about caring for individuals from underserved populations and what their perceptions were. Next slide, please. So this is just kind of showing the entire debriefing tool and the 5 different parts of it. If you look over in the right-hand column, and Sue had put a couple of nice comments and questions that all of the facilitators used. So like under reactions, we would ask, how are you feeling? Or is there one word that can describe how you're feeling following this simulation? And this would be done between the facilitator, the students, and the standardized patient, or if there was a support person, the standardized patient with a support person. And so it was really a wonderful way to look at what was done and to start probing into what students were learning, how they were feeling about this, and really set the stage nicely for the rest of the feedback session. Next slide, please. So we recruited students. It was a convenience sampling, that's for sure. And there was something very pragmatic about that. And that was really the only way we could get students. So our students were typically well, we had students enrolled in years 1 through 4 of the Doctor of Nursing program, dentistry, or pharmacy. Most of our students were at or close to the end of their program. The survey data collection occurred over about a 9-week period using electronic methods. We had a baseline self-efficacy for collaborative practice that using the IPEC set 27 to measure the participants' self-efficacy for competence and collaborative practice behaviors. They would do that prior to starting the sim. And then at the conclusion of the sim, when they had finished the entire session, they also then went back and did the IPEC set 27 for a post-experience data collection. Next slide, please. There were statistically significant improvement in mean collaborative practice behavior scores demonstrated by all of the professions for all 27 items immediately after the IPE simulation experience. So that was pretty significant. The greatest mean change was seen in the teamwork item. So that would be in that IPEC competency. And we have the mean and standard deviation before and after here. And this would, then we also had qualitative responses, which when we went through all of the recordings, we were categorizing them according to IPEC competencies. In this case, we're showing describe the process of team development and the roles and practices of effective teams. And so this TT1, as we called it, was the most reported change in practice behaviors. Values and ethics was the least reported. Next slide, please. So these are some examples of the comments that were made by students during the recording, during the debriefing that we actually extracted from the recordings. So I'll just go to values and ethics. This was a statement made by a farm student. I feel that all of us displayed a heightened sense of compassion and empathy, which is extremely important, and made this go really well and still made the patient feel comfortable and wanting to talk to each and every one of us. And I have to say it was statements like that, as particularly going back and listening to the recordings, that really gave you a sense of how important and how significant this is as an educational tool that could be used, I think, universally. Next slide, please. So our next steps, which we have started this year, first is to expand to other colleges and universities. So we fortunately have Temple, or unfortunately, because we have Temple because Sue Kilroy left UIC and went to Temple. We're still not happy about that, but we're happy for her. We've been at least trying to get participation from the UIC College of Medicine. My own idea was that we will try to get this to all 7 healthcare colleges here at UIC and get participation across our entire West Campus. The other part is creating a package, an education package, a budget, and then that package would also contain facilitator and SP trainings. We did a lot of training in this project. I failed to mention, even with the Pearls and the Pearls debriefing model is we did a couple of trainings with our facilitators. And in addition to that, we had some articles and literature on the Pearls topic that all helped to keep our facilitators somewhat consistent in how they approached each SIM feedback session. Next slide, please. And then disseminating the information from the study. We are working on an article right now. So it's going to be published last January at the IMesh meeting. That's the International Meeting for Simulation in Healthcare. We presented this project, and you can see those famous presenters there in that upper left-hand corner. And of course, we're doing this today with PATH. And so that's another hopeful way that we'll be able to disseminate it. Because Bridget Brown was part of this as a standardized patient actor and is also a co-op student in the Department of Disability and Human Development here at UIC. She actually had an article about her that appeared in this blog from the Office of Special Education and Rehabilitation Services, which is part of the U.S. Department of Education. You can Google that and read that. And then also in UIC Today, so this would be across our university here at the University of Illinois in Chicago, we had an article about the training and the scope of our project last year. Next slide, please. And I'm going to turn this over to Bridget, who has a few comments about her experience as a standardized patient.
I'm going to talk about the participation. So I felt I was included in the whole project by the nursing, pharmacy, and dental students, and the nursing department, Sue Kilroy, Lynn, Katie, and Chris. Students asked good questions to help me as a patient. I understand what was going on. They explained things well for the patient. In the case, Dana, who has disability, they showed me respect and they treated me as someone with ability and not disability. SB training. The training was good. Chris and Sue did the training. They helped explain the entire project so I could understand it and play my role. Chris helped me a lot with the training and to be an actor. He shared tools and strategies that help include people like me with disabilities to play the roles given up for us. For example, he gave good training recommendation for providing positive feedback. If I was a patient, I felt like the briefing process. It was good. It was positive, building relationships and connections to the student providers. Chris training helped a lot of giving strategies on how to give feedback to students. I felt really good about giving feedback since students listen my ideas and understanding to become better. In future recommendations, I continue doing projects like this all over the USA so students can learn to work with patients with disabilities.
Thank you. Thank you, Bridget.
Thank you.
So I think that brings us to our end of it. If anybody has any questions, I can stop sharing now. And if anybody in the group has any questions for any of us,